Welcome, everyone. I am Kathy Brett with Becker's Healthcare and moderator for today's program. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as he can during the time we have, and will follow up on questions he does not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. Dr. Len Firestone is the Medical Director of Perioperative Services at Health Inventures. Over a 35-year period, Dr. Firestone has served as physician lead and senior consultant for the national healthcare practices of Deloitte, Accenture, Navigant, FTI, and others, after the previous role of anesthesiologist-in-chief and chairman of Presbyterian University Hospital in Pittsburgh, professor of anesthesiology and critical care medicine and of nursing at the University of Pittsburgh, medical director of the School of Nurse Anesthesia, UPMC, vice president, venture capital, Paramount BioCapital, NYC, and Executive Director, Chief Executive Officer, and Chief Medical Officer for 3 biotechnology companies. Dr. Firestone is a graduate of the Yale University School of Medicine and the Anesthesia Residency and Fellowships of Yale and Harvard. He holds an active Pennsylvania medical license and is certified by the American Board of Anesthesiology. It is now my pleasure to turn the floor over to Dr. Firestone to begin today's presentation. Thank you. Dr. Firestone?
Thank you very much, Kathy. Is everyone able to hear me? Kathy, am I coming in clearly?
You are coming in fine.
Okay, great. Well, let me start off and thank everyone for attending the webinar today, and welcome you all, and thank Health Inventures, as well as Scott Becker's company, for the opportunity to reach all of you today. I've had the privilege of reviewing numerous perioperative services in about a 14-year period of consulting. And so my overall goal today is to provide all of you, many of you are hospital administrators, with, I'll call it a roadmap to systematically and objectively review your own perioperative services program in your healthcare institution, and do so based on best practices. Next slide. Now, when I say top performance in an operating room, we could mean top clinical outcomes, top operational outcomes, which many people would say is equivalent to OR throughput, financial yield, growth of market share, and in specialized academic hospitals, even teaching excellence or research excellence. Today, the focus is going to be on operations, though I would say that finance and growth generally track very closely to an operationally successful perioperative services. And we'll leave clinical outcomes to medical staff. It's a different topic for perhaps a different day. So next slide. I'm going to start by paraphrasing the great Russian novelist. Over the years, we've learned that happy ORs are all alike, but every unhappy OR is unhappy in its own way. And by that, I mean, in other words, that each OR is a unique blend of people and process and technology, as I'm sure you all know. And based on that unique blend, we get unique problems and unique opportunities. What I would say is that top performers avoid the common pitfalls. They're like the happy families all alike. And I would also say that the top performers have hospital administrators that have proven key to that success. Next slide. Now, in our view, the key elements of top performance are in three major categories: governance, management, and core process. And we'll spend the rest of the time in this webinar going through these. By governance, I mean the leadership needed for policy making and decision making. Management in general in operating rooms comes in two varieties: the conventional type that most administrators would recognize, the cluster, if you will, of OR director and the relevant department managers, who take what I would say is a longer range view of activities, but equally key to success is a second type of management, the daily OR charge team, who are concerned with shorter range activities, executing the daily OR schedule, as we'll go through in some detail. And then finally, the key element of core process, which are the underlying, say, enabling business processes of perioperative services. In top performing operating rooms, we've learned that these elements are distinct, they're easily identified, they're not vague, they're not blurry. So next, we're going to drill down on each one of these. Next slide. First, governance. We believe that a robust OR governance mechanism is fundamental to everything else we're going to talk about today. In short, all top performers have strong governance mechanisms, and dysfunctional operating rooms don't have strong governance mechanisms. So what forms governance? We would say it's an interdisciplinary leadership group consisting of medical staff, the surgeons and the anesthesiologists, the nurse executives and managers, and certain key hospital administrators, and this will vary from institution to institution. Part of the art form is putting together a very functional governance group, no different than putting together a corporate board. Perhaps the COO should be on the governance group of a very large hospital, or an executive that reports to the COO. Certainly somebody from finance and the leadership of the medical staff, the leadership of the nursing staff, the CMO and CNO. And I would make the point also that the individuals chosen to be on this leadership group matter. The qualifications are, of these individuals are that these people be role models in their own activities. If they're not credible as leaders, as the CFO or the CMO, they're probably not, ideal to be on this governance committee. They should be good negotiators, both able to listen and able to express themselves in ways that build trust. And they should be people who see the big picture and not get bogged down in the issues du jour. When I was in private industry as a CEO and as a board member, I learned that functional boards have people who have qualifications in this respect. I think the same is absolutely true for the operating room. In the corporate board model, the people on the board are not necessarily representational. It's not a democracy. Every constituent does not need to be represented. The model is more fiduciary, where the people who belong on this governance board are the custodians of the business of the operating room, really not self-dealers. And the more representational the board is, the more people are motivated to self-deal, if you will. The highest priority, I would say, for this governance group, in our experience and gained from top performers, is to unify the vision. And if we're looking for top performance around operations, they should unify the vision around operational performance. Next slide. Now, this governance group's responsibilities resemble that of any top-performing board, if you will. They need to act as a body. Fractious behavior or distancing, one board member distancing themselves from decisions of the rest of the board is really toxic to successful performance and shouldn't be encouraged. Responsibilities also are to establish policies and in some cases enforce these policies. More can be said on that. To establish the metrics for the business, establish an operating room dashboard with key performance indicators, and then define those key performance indicators in great detail and set the targets based on some rational understanding of what best practices are. I believe in operating rooms. The governance board should also set and monitor OR capacity. OR capacity is the core of the OR business. It's both the great driver of revenue and a great driver of expense. And until an operating room is a top performer, and even for a good long while it is a top performer, the governance board should concern itself with monitoring OR capacity. The governance board is there to support OR management's plans, not to tear down OR management. And I think that's quite different than what we see in many operating rooms that we visit. The governance board, members on the governance board should be invited to write performance evaluation for the managers in the OR. That's where accountability lives. And they should help keep the focus on OR process improvement. Once the governance board is formed and functioning, and the charge team is formed and functioning, it's very important to continuously improve processes in the ORs. Surgical medicine is very fast-moving. Technology is very fast-moving in ORs, and it's necessary to constantly improve. And naturally, like any board, the responsibility of perioperative governance is to communicate to the rest of the OR community and stay on message and keep those messages succinct and potent. The authorities that we've found in top-performing operating rooms are to create clinical and scheduling policies, the standard protocols, the procedures in the operating room. We would emphasize also that the governance board should be in charge of allocating block time. That doesn't mean involved in the minutia of calculations of percent utilization, but that does mean making policies on how block time is allocated and how block time is maintained for individuals or for groups or practices. This is important, and this is very different than in many hospitals. Top-performing operating rooms and their governance boards oversee block time, in detail, and that enables enforcement. Much of the trouble in operating rooms, the underutilization, the excessive expenses relate to poor block time utilization. Other authorities may also be useful, and some top performers we've seen the board get very actively involved in recruitment of management positions, and as I mentioned earlier, performance evaluations, and this really engages the medical staff. The governance board should be consist of many medical staff, surgeons, the big users of the operating room, several key leadership anesthesiologists, and of course the nurse executives, the entire clinical team, not necessarily representational, but people who know how to negotiate. So next slide. I mentioned that top-performing ORs have well-developed metrics in the form of OR dashboards, which I probably don't need to tell this audience is a very dynamic tool for continuous improvement. If you can't measure it, you can't improve it, some people have said, and so it's one of the fundamentals of top performance in the operating room. All too often we find when we go to hospitals that OR dashboards are just used as management reports. Managers talk to other managers about what the case hours are and the case volume and the turnover times and the suite utilization. We have learned from top-performing operating rooms that when OR dashboards are owned by the entire OR workforce, where everyone in the OR can point to something on the dashboard and say, that's me. I'm the one who drives the needle. I can move the needle on this part of the dashboard. And when people have that level of understanding, you get a top-performing operating room. The dashboard should be posted on the walls of the operating room and in the lounges associated with operating room. And they should be branded. They should contain the recognizable metrics that relate to presentations in the various departments, that relate to how administrators address people in the operating room, and how the operating personnel address each other. So suite utilization in even the most complex operating room, suite utilization should be better than 70%, perhaps 75%, even in transplant and trauma centers. And of course, in a less complex environment with more rapid turnovers, we should see upwards of 90% suite utilization. First cases should start 90 to 95% of the time on time. And that's not just webinar discussion. We see that happening. We have seen Many institutions go to from 40% first case on-time start. We're talking about institutions of 25,000, 30,000 cases a year to 95% on-time starts. But the definition of start time has to be perfectly clear, and there has to be focus on operational excellence. It has to matter to administration, and it has to matter to those hospital executives. The turnover times, of course, should be appropriate to the case. Even short turnover times may be too long if a case is, a 5-minute case under anesthesia. Case cancellation rates should be as low as possible. Something in the 1% to 2% range is achievable and very common in top-performing operating rooms. Dashboards should also contain safety metrics and service metrics, and we advocate trying to keep them succinct, not having endless numbers. The dashboard shouldn't change from month to month. Try to have dashboards with performance indicators that are standard and followed and trended for 6 to 12 months. The numbers should change every month with a refreshment of data, but the endless search for the important parameter and a constant changing of the dashboard is actually an enemy of your staff taking ownership for the success that's reflected in that dashboard. So there are many safety metrics. Some of them are quite related to the activities in an operating room. There might be problems in the PACU reintubation rates and headache after labor epidurals. So these are kind of specific areas. More generally these days, operating rooms are concerning themselves with compliance with timeout processes and surgical site infection rates, surgical care improvement program endpoints. I think many of those things we're all on this call aware of, so we don't need to reiterate them, but a dashboard devoid of safety metrics is sending the wrong message. There should also be service metrics, and I think here is where we find the greatest opportunity, the greatest differences between mediocre performance in operating rooms and really the top performing operating rooms in the country. If recruitment and training of nurses is a key priority, if your ORs are full of travelers and the surgeons are complaining about the skills of the nursing staff, that could be a service metric. And recruiting, training, refreshing the skills of your staff could be something that really is measurable. This is a big satisfier among the surgeons on a governance board, and we would urge the staff and the administrators listening to the webinar today to ask themselves in their own programs, what are they trying to achieve in the next 3 months or 6 months in their operating room? What's the biggest source of complaints among the medical staff and the other clinical staff? And how can those things be reduced to performance indicators in the service area? If the anesthesiologists have promised to have all the patients cross the threshold of the operating room by 7 a.m., although that's not something that's entirely under the control of any single group. It's multidisciplinary for sure. But if individual groups have made service promises and commitments, could those be reduced to performance indicators, and can they be measured? If surgeons have committed to sign consent forms and have the surgical site marked by 7:15 a.m., what's the proportion of time in a given week that occurs? These are the kinds of service promises that an OR dashboard can track, and this is where accountability can come from. Next slide. Now, we've learned from top-performing operating rooms that OR management is clearly segmented into 2 types. One type is what most hospital administrators would recognize as, OR management. In other words, the cluster of OR directors and managers. But I'm going to start off talking about a more acute type of management, which I think is important to separate from the other kind of management because, the goals and the skills and, in fact, the metabolism of the people who do this management is really quite different than the other type of management that we'll get into in a moment. So what is the daily OR charge team? Different hospitals have different terms for the group that collaborates to do this. It's an interdisciplinary team most frequently a charge nurse and charge anesthesiologist. We hope that the reason that they are placed in those positions of trust is that they're good at what they do rather than just happen to be the people on call that day. Top performing operating rooms don't allow very many people to be on the charge team because it requires a lot of specialized knowledge. Lately we've innovated and introduced the concept of a charge surgeon in operating rooms, which doesn't take very much time for the surgeon to participate, but it really is a game changer in terms of engaging your medical staff in their interest in having a reliable, predictable operating room environment. We can talk more about that if the audience is interested. In any case, the role of the charge team is to execute the daily OR schedule. It's much more short range in decision making. We liken it to air traffic control, which is what you see in the picture. And these are the people that are dealing with real-time challenges, the issues in the early morning and midday, the so-called witching hour at 3 o'clock, setting up the evening team to succeed so the whole evening isn't taken up with add-ons, and also looking ahead at tomorrow's schedule and being proactive in discovering problems and solving them before they occur in reality. The top performing operating rooms have this real-time management group reporting to the board of the operating room, if you will. This helps to break down silos. We find that the best operating rooms have their charge team really driven by metrics, principally utilization, rather than just lack of complaint. The people on this charge team group have to be very good negotiators, and their judgments have to be really respected because when you look at it, they're really the final court of appeals, so they need a really strong working knowledge of OR policies. And I would say to the hospital administrators in this audience, groups like the charge team don't form themselves and they don't train themselves. They all know what they're doing in their own silo, but forming a team where the success of the anesthesia team is greater when they collaborate with the nursing team than it is alone, and vice versa. Hospital administrators really need to catalyze the formation of this charge team in a highly deliberate way. Next slide. So briefly, now I'm going to address the second, perhaps more conventional type of OR management, the OR director and his or her clinical and department managers. Now we're off the deck of the aircraft carrier, more on the bridge of the aircraft carrier. Notice the long-range binocular, surveying the horizon. So this is really offline. These are people who make decisions in conference rooms, and their decisions are longer range. The principal focus, I think, of this group is clinical management. Do we have enough subspecialty nurses? What's our staffing plan? What's the skill mix? What are the various competencies required, and how do we match them on a day-to-day basis? So this is your core of people that advise and connect to the core processes, and that's a different set of managers. All of these people, of course, are the long-range OR managers, but the manager of OR scheduling and pre-operative preparation, or pre-admission testing, some people call it, or materials management or sterile processing. So together this forms the longer range management type. Now what we've learned from experiences in challenged hospitals and experiences in top performing operating rooms is two things. Job descriptions are absolutely essential. When you look back at the job descriptions and try to relate them to complaints that that hospital executives have about the management of the operating room, or hospital directors or OR directors and OR managers have about each other, it's very hard to find unambiguous, clear job descriptions in the OR environment. And the same can be said about performance evaluations. Now, I think many hospitals are trying to address this, but I would say this is where the OR management success is make or break. Hospital executives are really the only ones to hold the key to quality job descriptions and quality performance evaluations for this group. Now, a few final words on management. Next slide. I just want to emphasize the point by using an org chart. On the left side, you kind of see clinical roles, a clinical director and certain clinical managers. Maybe the clinical managers are pre-operative preparation and, or I should say, pre-surgery holding or PACU, or neurosurgery or orthopedic surgery. These are your clinical brain trust. And on the right side, we see more business processes, the enabling processes, materials management, sterile processing, OR scheduling. You know, just like a left brain and a right brain, success depends on a healthy collaboration between the right and left sides of this chart. But I think the key message I want to leave the audience with today is that top-performing ORs no longer overburden their clinical directors with having to be expert at the enabling or underlying business processes. Instead, there's more emphasis for the clinical director to focus on staffing and staff education and staff quality, and allow the business management and the separate managers for materials and sterile and so on to focus on those areas. Next slide. So if our clinical group is focused on staffing, let's spend a few minutes on staffing. This should be, in our view and our view from top-performing hospitals, the principal focus of the clinical OR management. This is the crux of quality patient care. So of course, this consists of our circulating nurses, our scrub techs, the nurses in pre-surgery holding and in the PACU, and this is our content experts in our reservoir of experience. But hiring these people and filling out the roster really is just the start. There's skill development and maintenance, and that has to be done very purposefully. And that, again, is where the hospital executives come in. There's cross-training so that each staff member can be more of a utility player and therefore more valuable. There's the whole process of recruiting and retaining staff, which again has to be very purposeful. And sometimes the people in the operating room have a very difficult time motivating human resources to work closely. And again, this is where the hospital executive really needs to connect the dots. And then finally, setting surgeons' staffing expectations for the number of staff in his or her room, the skill set of those staff. When people finish orientation and can come into that room and begin to get their you know, the final phase of their education, which the surgeon provides. So the hospital executive plays an important role in all of that. Now, most of the people on this call, I think, are aware of the productivity benchmarks that are out there from national databases and some of the consulting company databases. I think productivity benchmarks and surgeon expectations is the principal guide to the hiring decisions, how many people to hire and what skills and what the skill mix is. And again, the hospital executive has to be very involved in all aspects of this. I should mention that there are numerous support personnel in the operating room, anesthesia, OR, transport technicians and assistants, sterile processing and materials technicians. The key here is that I put the support personnel, notice I put them in staffing, which is part of the clinical environment. If these individuals come in contact with the caregiving, then they need to be managed by the directors and the managers who provide the caregiving. So we can go on to the next slide. I'm going to delve a little bit deeper into the OR staffing plan. We kind of conceive of it as a target with several layers. You know, we're aware the core staffing plan, of course, these days consists quite frequently in hospitals with 8-hour shifts and 10-hour shifts and 12-hour shifts, depending on the length of block times and the skills that are required for various services, and that's how we cover prime time. There's a lot of ambiguity, much more than you would imagine as you go around to many hospitals, in what exactly is the OR capacity. It's often very hard for consultants who come in objectively to learn what are the hours of operation of a given operating room. And the larger the scale of the institution, the more vague things can become. So I would warn all the hospital executives on the telephone, don't succumb to the ambiguity of capacity. Have it clear in your mind. When does block time start and when does it end? How much flexibility can we offer to surgeons outside of block time? Because the staffing plan and the roster vitally depends on factors I've mentioned, but also the OR capacity. Now, beyond the core is the next layer, if you will, and these are the flexible resources that are wrapped around the core. But this is quite distinct from the on-call resources. Many hospitals will say our on-call people are our flexible resources, but we would urge the hospital administration to think that through. This is a major source of double counting, if you will, and double counting in the minds of medical staff and clinical staff is double talk. We have noticed that top-performing operating rooms try to work as much as possible with their staff and be flexible, but special deals in staffing almost always come back to bite. At some point in time, they need to be unwound, and if you allow them to accumulate like barnacles in a boat, eventually the boat will sink. So hospital executives need to monitor this quite closely. If that means connecting human resources directly with the OR director so they can work more closely together, whatever you do to promote that will be well worth taking the time. And of course, the labor productivity benchmarks are very important to hold yourself and the OR director accountable for the staffing plan. Just very briefly, cross-training can help you meet the benchmarks, making each staff member more functional and valuable. There's a tension between our society's need for subspecialization in the operating room versus the fiscal and operational importance of every person in the operating room being a utility player. If half of our workforce can only do liver transplants and nothing else, it's very hard to run an elective schedule and it's very hard to run an add-on schedule. So we've noticed that top performers will ask all of their staff to pick a major and a minor. The people who pick orthopedics as the major, they're the ones who set the bar. If they pick orthopedics as a minor and neurosurgery as a major, then they'll meet the bar in orthopedics, but they set the bar in neuro. And this is an ongoing, continuous process in top hospitals. It's not something we do once a year for 1 month. It's not something we do just at an in-service. Skill maintenance is very vital to top performance in operating rooms. There should be robust in-service training. The nurse educators should be people who are very interested and active in this area. And we recommend that hospital executives literally attend some of the in-service meetings, even if the content is a little out of their league. Let's take a look at the faces of the people attending. Are they very engaged? Do they look like they're learning anything? Are they asking questions? Are the presentations high quality, or are they just off the top of people's heads and everybody's mind is wandering? The next slide. So with the remaining time, we're going to focus on the OR core processes, OR scheduling, preoperative preparation, materials management, and sterile processes. Now what these have in common, and all of these can either undermine or enhance operating room efficiency in general, and all of these departments interface outside of the operating room. So this is where ambiguity and accountability is, and accountability can become weakened. Now sometimes people include in the OR core processes charge capture, but we see that as part of materials management, anesthesia, but we see that as part of governance and leadership, and sometimes we see information technology, but we believe that that's really integrated into the fabric of all of these core processes. So the first I'm going to cover, next slide, is OR scheduling. As most of you know, OR scheduling office has a heterogeneous variety of office functions. It's part telecommunications, customer service because it's the front door of the hospital for elective cases, surgeon office management and education. It's a math exercise because we're squeezing cases into the allocated blocks, using predictive scheduling where we try to predict case lengths best based on historical cases. Some OR scheduling offices concern themselves with block allocation and block release. Top performing operating rooms don't rely on their OR scheduling office to do those. Those are high-level functions and really more properly belong in the governance domain. OR scheduling connects to pre-op clinic appointments, connects to bed management, connects to materials management, so the right supplies and equipment show up in the cases. As you see, it's a very broad spectrum of activities and expertises. Next slide. So in essence, that same spectrum is also the source of the challenges. Defining the core duties, filling blocks and equipment requests and pre-op clinic appointments, and putting emphasis on that instead of the marginal duties is kind of job number one. Defining the department metrics and defining the manager's job description and the scheduling manager's metrics can only be done after you define the core duties of that department. And one of the most important things that hospital leadership needs to struggle with is OR scheduling only for surgical procedures, or is it for any procedural work like invasive radiology or cardiac catheterization or GI endoscopy? Because these interface with other departments, and what are those interfaces like? The OR scheduling manager really can't deal with that. That has to be at a higher level of hospital administration. But a good OR scheduling manager, once those aspects are defined, will be able to execute properly. I've mentioned that block time is best left to leadership. After that, the OR scheduling should focus on their efficiency. How many screens do they have to open to book a case? Can they use the fax machine instead of having live phone conversations? Can they use CPT nomenclature or surgeon's prior history rather than just free text, which very often leads to ambiguity? A hysteroscopy is a much different case than a hysterectomy. But if the hysteroscopy case card shows up, we have a surgeon that's upset, we have a case that's delayed, we have a patient that is endangered. The new medical records that are being implemented in hospitals are challenging OR scheduling offices to integrate the new technology. And all over the country, OR scheduling offices are challenged by how do we use predictive scheduling software. And what we've learned from top performers is that the software really can be quite shallow. The case characteristics are largely ignored. We've noted that top performers avoid overdependence on this kind of software. They will use it, but they'll also allow their surgeons to override, and then they use the Ronald Reagan doctrine. They trust the estimate, but then they verify, and they monitor the accuracy and adjust the case lengths accordingly. Next slide. Now, the next core process I'm going to discuss is preoperative preparation. Sometimes it's called pre-admission testing in hospitals, and that itself is revealing. Because the most important job here that the top performers have accomplished is thoughtfully defining the scope of this clinic and not just letting it define itself. The overall goal is to make patients ready to optimize for surgery. So all of the clinics prepare the patient's medical record. They gather files and documents and lab results and so forth. They screen patients in one form or another, either telephone or in person. Some of them, though, and only some of them, will do regulatory nursing assessments, medication reconciliations, insurance certifications and copays, and fewer still will actually deliver medical care, which is to say react to abnormal tests, decide on the need for consultants prior to surgery, or react to some change in the patient's status. And if I can have the next slide, I've illustrated it here, asking the question, who owns the medical care in your preoperative preparation center? If there's a hospital executive on the phone and they're really not sure of this, I would say that it's very hard to be a top-performing OR and have that question in mind. Does the surgeon or the surgeon's physician assistant own the pre-op medical care and the preparation and reaction to the abnormal laboratory test? Is it the internist that the patient sees once a year? Is it the advanced practice nurse that is in the pre-admission testing area? Is it the anesthesia department or the nurse anesthetist in the anesthesia department? And if so, when does that interaction occur? We find that hospitals quite frequently under-leverage the expertise and skills of their anesthesia team to be useful in preoperative preparation, but it's a huge burden, and the anesthesia department will need a lot of help if they're expected to execute on this. Sometimes all of the above is left to the hapless pre-surgery holding nurse, illustrated all the way on the right side. And of course, it's not conceivable to get months and months of medical care accomplished in a half an hour, and yet I would submit to you that a majority of hospitals all across America are doing this every day. So clearly, hospital executives need to drive this dialogue and seek clarity on this point. Next slide. So I've just briefly listed here the challenges for the pre-op preparation process, core process, if you will, the optimization of the patient, and we've just covered that. It's important also to be candid that new evaluations are very time and skills consuming. So if a patient sees if a patient is seen in a surgeon's office and otherwise shows up the morning of surgery, how realistic is it that all of that work can be done? But by the same token, the surgeon's office can also do nursing assessments, med reconciliation. So where does that belong? Hospitals are solving it in different ways. Top-performing hospitals have made the commitment to solve it in a clear way. More and more, they're recruiting the surgeon's offices to contribute to the effort. A number of years, the last maybe 10 years, the trend has been in the opposite direction. But as enterprise medical records are being implemented, the data now are much more secure and less likely to get lost. And so acquiring information, meds, and nursing assessment information in the surgeon's office is likely to be findable at a later date. And so slowly but surely, there's more of a trend in that direction. So in the last couple of minutes, I'm just going to touch on the two remaining core processes. Next slide. Materials management and sterile processing. And as most of you know, materials management is sometimes called inventory management because of the large inventories of drugs and implants and what have you. Materials management will also deal with consignment items, which are third-party owned, so they're not really inventory, and that's a separate issue. But key to inventory management are things like PAR levels, the reordering, minimum, maximum levels, and inventory tracking processes and storage locations. And to the extent that operating rooms are burdened with ambiguity in any of these areas, storage locations or poor labeling or an inventory tracking process that's not very clear, it's very hard to have a top performance in operations. Materials management will also involve case carts, will also involve equipment like microscopes. This may all fall under so-called materials management in the OR. Next slide. And I won't go into this in much detail because you can get a copy of the presentation in the coming weeks, but I just say that the major challenges are the interfaces I had mentioned before between materials management and hospital materials management. So who is it that makes the service promise for material management in the operating room? For example, if I'm a surgeon and I have a mistake on a preference card or I want to change one of my preferences, how long will that take? And will that rely on some administrator that I've never met and may not do it for a month? In the meantime, I have another 30 cases where I'm going to have to labor with an inaccurate preference card. So who is authorized to create policy, to purchase, to introduce new items? Top-performing operating rooms have asked themselves that question, and hospital administrators from top-performing hospitals are all over those kinds of questions, and they're really quite clear. If I can have the next slide. A final few words on sterile processing, which shares a lot of characteristics with materials management, but also has some unique challenges as well. Sterile processing involves instrument processing, but also inventory management, just like materials management in general. And there's much more of a staffing plan component in sterile processing because sterile processing is very labor intensive. And so matching the staffing plan to the time when instruments are being processed and are most needed is a component that many operating rooms are weak at. Of course, when we talk about instrument processing, we're talking about the whole cycle of decontam, assembly, sterilization, and finally distributing the sets. And the key in sterile processing is to have a goal of a short enough cycle time where every instrument isn't just a use for once a day, but at the same time you don't want to foster what we call flash or immediate use sterilization because it's not as effective over the long term in large populations. And so we want to be able to reuse instruments, but we don't want to do that at the expense of too high a proportion of flash sterilization. I won't go into the inventory management. We covered that in materials management. Next slide. Now, I've just listed the challenges to minimize inventory, of course, and the number and the weight of instrument trays. Hospital executives help their sterile processing OR connections to really focus on certain things, like instruments that are low utilization. They shouldn't be in every tray. Convert them to peel packs, and that way you don't need as many trays, or you don't have trays that are cannibalized just to get one certain kind of instrument. High utilization instruments that are used again and again and again. You really want to know which instruments those are, of course, and right-size the inventory. You want to avoid shortages by identifying high utilization instruments. Have a clear process for getting new instruments, online quickly, for finding out where instruments are stored so that, again, we don't have these shortages. It's very important for hospital executives to understand where backlogs come from, the adequacy of their washers and autoclaves and what have you. These are the kinds of aspects of sterile processing that hospital executives can support and help their operating rooms become top performers. Can I have the next slide? So just to wrap up, I would say that there's considerable return on investment driving an operating room to top performance. And hospital executives on this call will want to ask themselves, what can I gain by going on that journey and promoting top performance? Well, almost always we can say, as honest brokers from the outside, as I hope consultants are, almost always we see supply and instrument costs fall. We see OR staffing costs fall, getting the same work done, sometimes with less people, but quite frequently to minimize the amount of overtime, for example, by clarifying the on-call shifts and the capacity that you need to get your volume done. Quite frequently, the top performance will yield value in minimizing anesthesia staffing costs because capacity is rationalized. It's hard for me to meet an anesthesia department that doesn't know of loads of areas of inefficiency in their operating room, the way they're staffed. Charge capture improvements is not uncommon. And very importantly, increasing the OR capacity during prime time for volume growth. That allows you to recruit new surgeons. So this is an area of increasing revenues rather than reducing expenses. But all of these will improve the financial yield. There's a few areas that driving top performance will help that doesn't result in cash necessarily, but will result in more reliability and build your brand. If you increase your capacity during the day without adding any new staff, but your OR becomes more efficient and wastes less time between cases, for example, gets started on time, gets cases done more efficiently, even if there aren't new surgeons to recruit, you might be able to get your add-ons done earlier in the day. I recall one of our clients was thrilled to see that their add-on lists didn't extend past 6 or 6:30 at night, where once upon a time they had gone until 11 at night to get the same cases done. And the general reliability and building your brand as a reliable operating room is very important. Patients talk about it, staff talks about it, families recognize it, and that's what I was representing by the award from J.D. Power. So our next slide, the final slide in the conversation today, just deals with what a perioperative assessment is like. Clearly in perioperative services there are many, many moving parts. Hospital executives may want top performance but just not have the hands to get there or the attention or the focus to get there. There are consultants, very good consultants, who can provide resources to do these assessments and implementations. And I'll use our company, Health Inventures, as just one example of what a good perioperative assessment is typically like. In an average size operating room, let's say, 12 operating rooms. It's a process that's, 6 to 8 week process, smaller operating rooms, somewhat less, depending, again, on the hospital scale. And it should be a collaboration between physician and nursing executives. The absence of either will shortchange you on the core process side or shortchange you on the governance and high-level management side. And also there are analysts and process mappers as part of the team. The report, after the assessment is finished, should be very systematic. There should be appropriate benchmarks. The recommendations should be clear and a business case made for those recommendations. The best companies, and I hope we're one of them, are known for very systematic diagnostics, which will come out in your report. The presentation, the in-person presentation, frequently will be where the opportunities for improvement are really gone into in great detail, the work plan, the timeline, the roles of people in the system and the consultants' roles that they may or may play, and the metrics for accomplishing the implementation of the opportunities should be presented. And of course, there'll be considerable detail on governance and your dashboard, your 2 types of management, and the various core processes that we've discussed today. So if we can just go to the next slide, I'll put up Health Inventures' address and their website, which you're welcome to visit. They have an email address. If any questions come up that don't get answered in this question session that we have planned, you're most welcome to email or call the company, and I personally will make every attempt to answer your questions. So I'm going to pause there. I think we have a few minutes for questions.
Thank you, Dr. Firestone. Your presentation was very informative and enjoyable. We're going to open up for questions now, and as a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Dr. Firestone will attempt to answer as many questions as he can, and we will follow up on any questions he does not have the opportunity to address. Dr. Firestone, we have an attendee who has a question here. She would like to learn more about the charge surgeon structure.
Sure. Well, thank you very much for that question. The first comment I'd make is that we have found many clients are intrigued with this idea. First, let me start telling you what it's not. It is not a full-time or even a part-time position where a surgeon functions as medical director of the operating room or, sits with the charge nurse at the front of the OR desk and makes judgments and helps run the operating room. That is not what a charge surgeon is. What a charge surgeon is an operating surgeon who is well respected by colleagues and who has a real interest in having the OR be very reliable. What we've learned is that surgeons not only bring cases to the operating room and in some cases problems to the operating room, but they also are very resourceful at bringing solutions. And in many hospitals, the charge team structure consisting of just an anesthesiologist and a nurse, as potentially powerful as that is not as powerful as the triumvirate. There are 3 very strong interests in the operating room: the nursing staff, the anesthesia staff, and the surgical medical staff. All of them should be part of the daily charge team management, in our view, rather than leaving an important constituency, the surgeons, on the sidelines, and the only way they can influence the dynamics minute to minute and hour to hour is either complain or take their cases elsewhere or threaten to take their cases elsewhere. We've found and found in top ORs that the involvement of the charge surgeon as a full-fledged member of the team who participates briefly in the morning huddle and in the midday and afternoon design of the wind down of the OR schedule is very useful. And where surgeons are particularly useful on the charge team is to look at tomorrow's schedule because they know a lot of the habits of their colleagues and they're able to make observations with their surgical insights that their anesthesia and nursing colleagues really may not make. And they also bring many solutions given their networks of surgeons and their personal relationships with their colleagues that aren't available to the more conventional charge team. So I hope I've answered that question.
Okay, thank you. The next attendee would like to know, how do the top performing ORs balance the need for flexibility, access to schedule, and high OR utilization?
That's a great question because it's at the core of the OR business. You know, if you provide infinite access, you can go broke because your staffing is, off the charts. And you can also disappoint everyone because it's very, very hard to hire, even if you had infinite resources, which nobody does. It's very hard to hire all the personnel in anesthesia and nursing that's possible to open up all of the ORs that surgeons could wish for. So it is always a dynamic balance. I think the comment I would make to an audience, general audience like today, is that the short answer to the question is meticulous management. If you schedule cases through your OR scheduling office, and that's all you do to set up your OR schedule, you'll either undershoot or overshoot in terms of capacity. You'll either have too little access because there'll be 14 add-ons and no place to put them, or you'll schedule a day in the operating room where a third of the operating room sits idle because, lo and behold, it's spring break, or lo and behold, there are many surgeons that just went to the orthopedics conference. So the answer is meticulous management. It's a combination of shrewd understanding of the OR scheduling office, and then the daily charge team managing hour to hour, day to day, to manage that capacity, open it up when it needs to be opened up, but also have the power and the authority and the judgment and the buy-in of the other medical staff to ratchet down capacity when you don't need it. The last thing I'd say is the other aspect of the charge team is that they should review the success of their management strategies for the prior week. We have advocated, and it's turned out to be very successful, and many top performing operating rooms have now embraced this, to meet on a weekly basis for just 15 minutes and review the data from the prior, let's say 5 or weeks worth of OR scheduling days to find out how high their utilization was and to find out what the recurring problems were. So a combination of real-time and some retrospective analysis by the charge team, and connecting the dots between the OR scheduling office, which is the course adjustment to filling the capacity, and the daily OR management team's fine adjustments, if you will, to adjusting the OR capacity. Connecting those dots, which the hospital administration is pivotal to, is the way to, succeed at that dynamic balance between access and utilization.
Thank you. Next question. How do those top-performing hospitals balance between physician-preferred items and more cost-effective items in their materials management?
What we've seen the top performers do is engage, and again, I'm going to give you a short answer so that it's crystal clear, and then explain that answer. I would say the short answer is to engage the surgical staff. Now, we've seen the governance group appoint subcommittees that focus on supplies, and will literally have administrators do the value analysis and set up all of the data, but then have key surgeons on a, let's say, a supplies or supply chain subcommittee of your governance group, so that the relative importances can be looked at. Because when you really think about it, in an era of finite and shrinking resources, if one surgeon gets a preference item, technically another surgeon may not. And so surgeons making the case to surgeons about where the importance of those preference items are and what the alternatives to them are is really going to be the only way going forward to balance all of those interests. Now, that said, sometimes there are business imperatives that hospital administrators are familiar with that the surgeons may not be familiar with. What I would say to that is, and how that affects this surgeon preference item aspect, is this is part of good governance in the OR. And so the hospital administration needs to be adequately represented on that governance team and, in fact, on that supplies subcommittee, if you want to call it that, so that the business imperatives underlying some of these preference items, let's say, let me give you a specific example, the robots that are proliferating, and why is it that we're getting a second robot instead of so many less expensive preference items that other surgeons think they need. Well, if the hospital is going to make a decision like that, I'm sure there's a compelling business case, and the more willing they are to be transparent and work with surgeons to present that business case, the more likely it is that there'll be constructive working relationships going forward, and which will allow your operating room to be a top performer.
Okay, thank you. We have time for just a couple more questions. Here's one for you. Please describe any change management issues you have encountered in dealing with administration, surgeons, and/or nursing staff.
Well, the first thing is to be perfectly honest. Where are the change management issues? In every single thing that I said today, there are change management issues. So the occurrence of issues is not a reason not to do it. Managing those issues when they arise is the art form of process improvement. Consulting companies are good at that. I happen to think we're very good at that. But hospitals can be very good at that too, and increasingly they need to be. So the first point to make is that there are numerous change management issues. But once a group of constructive people who are in charge of resource allocation, as a governance group would be in a perioperative service, recognize that change management ain't easy and there are numerous issues, if they treat each other civilly and they create a context for negotiation and they work to build trust, then those issues do not have to be toxic or rise to the level of toxicity of top performance in the operating room. In fact, they foster top performance. So we've seen lots of wonderful stories where there had been considerable rancor in operating room decisions. And in fact, if you proceed judiciously, communicate often, engage the clinical staff. Notice I didn't say just medical staff. I mean all clinical staff. And make a good case for why the change is being made and get their input into what the changes are. What I've learned is that, in ORs that have functional challenges, the clinical staff are well aware of it, and there is virtual unanimity that something needs to change. The only question is what needs to change? And if you ask the clinical staff their opinion of what needs to change and try to find the common ground, they like it, they get used to it, things change, and they change for the better.
Okay, thank you. One last question. Could you comment on block release times in top performing ORs?
I would be delighted to, because this is a subject of continuous discussion. All surgical practices are not the same. All subspecialties are not the same. There are some practices and some specialties that the practice is highly urgent. If your family member gets a diagnosis from the radiologist of an abnormality on her mammogram, that's something that needs to be addressed right away. It's not like a dissecting aorta, but it might as well be, because that weighs so heavily on the patient's mind. So there are some real reasons why surgeons need block time, and they need to hold on to the block time until the bitter last minute. Referral patterns can be jeopardized if cases are not done in a timely way. This is particularly true in the cardiovascular rooms, and there's a tremendous amount of competition for those cases. On the other hand, there are services, joint services and some others that lend themselves to scheduling weeks, if not months in advance. So, it's a continuous negotiation. There's not one size that fits all. What I would say is that what we have found where there's room for common ground is that if certain services need call it zero block release time, and they need to hold on to their block time till the bitter end because they may have urgent cases coming in all the way to the last minute, then that's okay. We understand that, and if it's medically valid, that's appropriate. But this is where hospital administrators become so important, because there should be good data that document that patients are scheduled who haven't been in the hospital or were scheduled for a given surgical day no more than 12 hours before that day began, or 24 hours before that day began. So there's a certain amount of data that can inform our decisions. Other than that, it's a continuous negotiation, and you try to find areas where there are services that don't need it, there are services that are needed, do need it, and hopefully the perioperative governance group will help everybody come to peace with the reality that not all services are created equal in this particular characteristic. One other thing I can say is that if a given service or a given surgeon has a few blocks simultaneously, they don't all need to be held for zero release. So there might be a group of neurosurgeons that have, runs 3 rooms at a hospital, but they're worried about brain tumors and brain biopsies, or perhaps revascularizations on an urgent in-house basis. Well, if that's the case, maybe they can reserve one of the operating rooms for that. They don't need to reserve all 3, and in that way we can preserve our ability to do elective cases that start on time and not bump other surgeons unnecessarily and disappoint those families. Hello?
I'm sorry, I was talking with my mute button on. I want to thank you, Dr. Firestone, for your excellent presentation and for all of you who participated today. We look forward to having you join us again for future webinars. This will conclude today's program, and have a wonderful afternoon. Thank you.